everyone. I'm beyond excited to have you all here at the kickoff for this webinar series. AIR, if you're not familiar, is a nonprofit and one of the largest social and behavioral research and technical assistance organizations in the world. I direct the Center of Addiction Research and Effective Solutions, CARES, at AIR. I'm a social epidemiologist, a harm reductionist, and someone who brings personal experience, research, and humility to the work that I do. I also lead a multidisciplinary team to think through how we can promote the social determinants of health to address the needs of those directly or indirectly impacted by problematic substance use, to support people who use drugs, and to prevent overdose. So AIR CARES saw a need to bring people together to think more critically about the social determinants of health. And that is how this webinar series was born. And so this is the first of a whole set of webinars on the social determinants of addiction. And the response has been overwhelming. We had over 400 people register for today's event, and from healthcare, social services, public policy, housing, employment, education, the criminal legal sectors. You all are program administrators, educators, policymakers, service providers, researchers, and community members. And you also are people who are interested in understanding how we got to where we are today. You're interested in understanding how that history affects people today and how we can elevate the stories of individuals. You're interested in understanding what is at the root of this unrelenting overdose epidemic that we're in. And you're interested in what practically needs to be done right now to save lives. So over the course of this webinar series, we hope to unpack the complexities. We hope to take the injustice out of the shadows and make space for conversations that can lead to change. And so in order for those conversations to take place effectively, we need to have some real talk about structural issues that keep us from saving lives, so we can embolden advocacy efforts. We need to have practical examples for taking action that are evidence-based. And when there's room to learn about innovation, we need researchers who are ready to interpret their work for audiences other than researchers. And most of all, we need to be centered. We need to have that conversation centered on people whose lives we are hoping to impact. Nothing for us without us. And this isn't just a token inclusion. I see this as an essential to really understanding what researchers have missed, to understanding what policy has missed. And this is really about listening. Too many people are dying for us to keep doing what we've been doing. And this means rejecting the polarizing narratives that keep us from working together and finding common ground for change. And so I hope that this webinar is a way to bridge and connect our shared goals. I'll just note that you can, throughout this webinar, use the chat function to the Q&A box to put your comments and reflections and questions in for panelists to see. And then we'll be addressing those comments and questions after the panelists speak. So we have, for this webinar series today, our goal is to set the stage for the year and to provide some foundational information. In March, we'll tackle the challenges of healthcare access for people who use drugs, harm reduction as healthcare, financing, policy. And in April, we'll talk about employment and housing. May, criminal legal environments. In September, we'll cover prevention, education, and social support. And then we'll conclude the series in October, providing sort of an overview of what we've learned and thinking ahead. For our agenda today, I'm really excited to have this great panel participate for our webinar today. Regina LaBelle will give, after I give some background information and social determinants of health framing thoughts, Regina will discuss policy. Anthony Solandi will talk about the importance of centering people in the work we do, and Elizabeth Salisbury Abshar will share some work that highlights the relationship between the social determinants of health and overdose and how that impacted her understanding of the problems on the ground in Chicago. So let's get started. So with COVID, a few years ago, feels like a lifetime, but you might remember that in 2018 and early 2019, some thought that the country might be turning a corner on overdose, and the US overdose rates were high, but the country as a whole was starting to level off. And the story for people of color, however, was very different. You can see that the year-over-year rates for white Americans were decreasing or leveling off. And at the same time, fatal overdose was on the rise for Black and American Indian and Alaska Native people. So money was flowing to states, but these data suggest that these resources were not working for a large proportion of Americans. And then COVID changed everything, and we saw startling increases in emergency department visits for suicide, overdose, and other behavioral health outcomes. All racial ethnic groups jumped up dramatically in 2020. Black Americans, most of all, with a 44% decrease in overdoses compared to the year before. The research on pandemic-related changes show that about 10 to 15% of Americans saw pandemic-related increases in their drug use, including alcohol. And many people experience isolation, loss, economic strain. And this is particularly the case for Brown and Black people of this country who have carried the burden of higher rates of loss of loved ones during COVID, less access to healthcare, less of an economic safety net to weather the storm of job instability, and all the while watching our brothers and our sisters being brutally injured on the national news. You may also remember that for some people, during the whole George Floyd incident and other incidents, it made sense for some people to justify the brutality because the person had a history of drug use. Just think about that. US policies have been so dehumanizing and punitive that it has ingrained into our minds that some of our citizens are less deserving of protection from police brutality because they use drugs. If the pandemic can exacerbate the overdose crisis with such severity, it's not because we need more law and order. It's because people are suffering, and we have spent the last 50 years doing to people what this pandemic has forced upon the entire country in the last few years: isolation, economic exclusion, housing instability. These social determinants of the pandemic have been happening to people who use drugs for decades. Isolation through incarceration and harsh penalties for parents who use drugs, economic exclusion through discriminatory hiring and firing practices, and through the use of drug-related arrests and convictions to restrict access to basic needs like food and housing, as if drug use and substance use disorder is a rational explanation for why an individual should not receive benefits of being a citizen in this country. So that is what we have done. That is what we continue to do to people who use drugs. And our country has historically spent more money on law enforcement and interdiction, investing billions of dollars in an ideology that we can fix this mess that we created by stamping it out with force. And only in the last few years, you can see in this chart, the line graph, have we turned a corner by finally spending more on supporting our citizens instead of jailing them. On this supply side approach, this has affected people of color far more than white people in this country. Notice on the left that people who use drugs are by and large white. People who are, white individuals are a majority of our population. Naturally, they are a majority of the people who use drugs, yet they are not the majority of people in state prisons for drug offenses and federal prisons for drug offenses. So for decades, American voters have been mobilized to deal with the crime and poverty and drugs in the inner cities. And we all understand this to be code, whether we want to accept it or not. Code for Black, and poor. And our inner cities are filled with Black people because they were forced to be there through policy actions, through housing policy actions that we will discuss more in future webinars. So I call out these racial tropes as the falsehoods that they are, because these narratives have been used over and over to support policies that dehumanize, isolate, and exclude people of all colors who use drugs. And we have to name it to change it. So as we explore the social determinants of health in this webinar series, we will think through the structures of our society and how they interact with practices and people, and how having basic needs met or lack thereof creates a confluence of risk that can lead to what we currently see, this exacerbated overdose crisis. And this combination of discrimination against people who use drugs, inequitable implementation of our drug laws, lifetime collateral consequences of incarceration, and social determinants of health, which have a long history of excluding and isolating people of color. These things all come together and create acute consequences for drug use. So to get us started in this conversation, Regina LaBelle is a scholar and director of the Addiction and Public Policy Initiative at the O'Neill Institute. Ms. LaBelle focuses on identifying policies to reduce overdose and using the law to promote access to quality addiction treatment, harm reduction, and recovery support services. Ms. LaBelle also founded, directs, and is an adjunct professor in the Master of Science Addiction Policy and Practice program at Georgetown University's Graduate School of Arts and Sciences. She was an appointee in the Biden-Harris administration, where she served as acting director of the White House ONDCP. And Ms. LaBelle oversaw the establishment of the Biden-Harris administration's drug policy priorities, which included a historic focus on harm reduction services. And she served as the Obama administration, in the Obama administration as chief of staff at ONDCP, and oversaw the agency's efforts to respond to the opioid epidemic and other drug policy issues, including the implementation of the National Drug Control Strategy. Regina?
Thanks so much, Amanda, and thanks so much for inviting me to be part of this important conversation. As you mentioned, at Georgetown, I work to build the addiction policy workforce and on policies that improve outcomes for people who use drugs and those with substance use disorder. And as part of my work, I've noticed over and over how siloed addiction care is from the rest of the healthcare system. But as you said, there's an increasing understanding of the role that social determinants of health play across the continuum of care for addiction, from preventing the development of substance use disorder to treatment, harm reduction, and recovery. So from a policy perspective, policymakers have to look for ways to integrate these systems of care for addiction and those other services that include healthcare, housing, education, and employment. So we have to look at how we fund the continuum of care and identify the barriers that stand in the way of a vision for a more holistic approach to addiction. So I want to first begin by discussing how we fund these services at the federal level. And as Amanda said, the entire federal drug budget is over $41 billion. And this includes funding to counter international drug trafficking, as well as domestic public health efforts. Medicaid nationwide is the single largest payer of substance use disorder treatment. But there are numerous grant programs that also fund addiction services. And these grant programs are funded by the Department of Health and Human Services, but also by other departments, including the Department of Justice. Now, the American Rescue Plan included $4 billion for mental and behavioral health. And this included $30 million specifically for harm reduction. In the president's proposed budget for fiscal year 22, President Biden proposed increasing the substance abuse prevention and treatment block grant by 84% to a total of $3.5 billion annually. This program funds prevention and treatment for people who are under or uninsured in the United States. So when we look at the nation's addiction response, it's really a web of these services nationwide, from prevention to treatment, recovery, harm reduction. And this response includes addressing social conditions that can lead to addiction, risky drug use, and conditions that can stand in the way of long-term recovery. But they're often not integrated at either the federal level or when the funds are received by states and distributed to communities. One example is we know that the high prevalence of adverse childhood experiences puts young people at risk for addiction, as well as other adverse outcomes. So policies that can reduce adverse childhood experiences are also associated with a decrease in the prevalence of substance use disorder. So one policy example is a child tax credit. Now, the child tax credit, which expired in 2021, provided families with children $400 a month. It lifted 4 million children out of poverty. We know that trauma and toxic stress can lay a foundation for later addiction and early substance use. Reducing these conditions by lifting children out of poverty is the kind of long-term investment in preventing later substance use disorder that we need more of. But we often don't think of it that way. If we care about prevention, we have to be looking at policies like the child tax credit. We also have to look at what we fund at the federal level and how that funding is translated on the ground through states and local governments. Now, Medicaid expansion expanded the number of people eligible for Medicaid and increased access to substance use disorder treatment nationwide. But still, 12 states haven't expanded Medicaid. And even where it has been expanded, Medicaid doesn't cover the other types of services that someone who may have a substance use disorder or is in recovery needs. There are numerous funding streams and individual grants across the federal government that fund the entire continuum of care. But this siloed approach to funding leads to a siloed approach to care. And it exacerbates the racial equity and other issues we're going to discuss today. Now, there are a couple positive steps that have been taken to integrate care. SAMHSA, the Substance Abuse and Mental Health Services Administration in the Department of Health and Human Services, if the fiscal year 22 budget passes, includes a recovery set aside and a recovery office. This will have an opportunity to build stronger cross-cutting approaches to people in recovery from addiction. And some states have also built coordinating structures to bridge gaps between public health and the state's substance use disorder systems. But this will take time and political will. So building responsive communities, reducing stigma, developing a sustained approach that doesn't treat the issue of addiction like it's episodic, moving us from rescue to recovery, all of these steps are required to reduce the harms that can be associated with substance use disorder and build an effective response. So thank you very much. And with that, I'll turn it over to Amanda.
Great, thank you so much. So many great points there, and I particularly appreciate how you've elevated the need to support parents as an intergenerational approach to prevention. I hope to continue that conversation and many more, unpacking a lot of what you've said in future webinars. So with that, I would like to introduce Dr. Anthony Salandi. He is the Managing Director of Programs and incoming Interim Executive Director of the National Harm Reduction Coalition. He's been developing and advancing data-driven solutions to address complex and social and organizational challenges for over 20 years. He's a very skilled at monitoring and evaluating and in the nonprofit sector, particularly an adept researcher and strategic consultant whose work has guided the development of state and federal policies across various fields. Dr. Salandi is a fierce advocate for health equity and social justice. As a senior researcher at the University of Delaware, he co-designed a novel interactive ethnic-specific harm reduction intervention for drug-involved reentry populations, which is now a SAMHSA promising practice. Most recently at Mount Sinai, he oversaw expansion of the research portfolio for adolescent health.
Thanks, Amanda.
Dr. Salandi.
Thanks, Amanda. I appreciate it. At the National Harm Reduction Coalition, We define harm reduction as a set of practical strategies and ideas aimed at reducing negative consequences associated with drug use. Harm reduction is also a movement to social justice built on the belief in and respect for the rights of people who use drugs. In addition, it incorporates a spectrum of strategies that include safer use, managed use, abstinence, meeting people who use drugs where they are, and addressing social determinants of use, along with use itself. Harm reduction manifests unconditional love, unmotivated by the possibility of reciprocation or reward, or political points and positioning. Rather, harm reduction is powered by humanity, compassion, and understanding. Harm reduction also promotes equity and social justice by tying practical pro-health and pro-social strategies to building agency among people who use drugs and or do sex work, and acknowledges what has worked well for specific communities. Harm reduction recognizes the role of trauma, social determinants of health, and the inequitable impact of local and federal policies and policing strategies, and the inadequate access to healthcare, housing, support for marginalized communities. The social determinants of problematic drug use are vast and are best uncovered from the stories told by people who use drugs, those who have lived experiences, and by the loved ones of individuals who have died from accidental overdose. For instance, we have learned from retrospective studies that experienced trauma as a result of abuse and neglect in childhood are linked to initiation of drug use in adolescence. We have learned from studies that adolescent substance use and friend substance use tend to be highly correlated, and together are robust predictors of problematic patterns of usage for all substances in early adulthood. We know from examining data that drug use among older adults has been under-identified and underreported for decades, especially for Black, Brown, and Indigenous communities. As important, sex workers are also centered in harm reduction because there are a lot of similarities. Both are a stigmatized and criminalized activity, and much like people who use drugs, people who engage in sex work are marginalized and criminalized for the choices they make about their own bodies. The realities of poverty, class, racism, social isolation, past trauma, sex-based discrimination, and other social inequalities impact people who are engaged in sex trades, vulnerability to and capacity for effectively dealing with sex work-related harm. At NHRC, we are committed to creating real space and resources for sex workers and highlighting the important intersection in our work. Even though we are here today to discuss the social determinants of health, I can't help but think about the political determinants of health. As we gather on this webinar, Senator Rubio and Senator Cruz are promoting the PIPES Act. And they were willing to shut down the government and prevent quality health care for our brothers and sisters, all for political theater. Thus, when we think about social determinants of health, let us shed light on the political determinants of health. And yes, centering people who use drugs and persons with lived experience must be prioritized in policy, research, and program spaces. Too often, failed programs and policies and research that isn't generalizable to Black, Brown, and Indigenous communities are products of poor design and historical institutional racism. When evidence-based programs are scaled without consideration to contextual factors and social determinants, we run the risk of causing additional harm to the very populations we seek to help. We sometimes wrongfully lay blame for programs and policy failures on those very groups, and successes are often attributed to policymakers as if they did the hard work. So here are some specific examples of centering persons who use drugs and their lived experiences. In research, NHRC has worked in California with SSPs to understand how people who use drugs use their services and get a granular understanding of drug consumption patterns. NHRC has also worked with AIRS, SSPs, and other user unions to establish a research advisory council comprised of people who use drugs. The council will help develop research standards and design studies that are relevant to the community. For policy, SAMHSA has created a harm reduction steering committee comprised of individuals in the harm reduction movement. They are tasked with developing a harm reduction strategy for SAMHSA that will help inform program and funding initiatives. Also, there are many policy advocacy groups like Vocal New York and DPA who echo the voices of people who use drugs while working tirelessly to get the medication-assisted treatment bill passed in Congress, as well as other policy initiatives. And success does come when we center marginalized groups. Just last year, the trans community in New York and our allies in New York got the New York legislature to repeal the 1976 penal law statute aimed at prohibiting loitering for the purposes of prostitution, but which ultimately led to years of law enforcement discrimination against trans people of color. For practice and services, during COVID, support services for people who use drugs were hampered by social distancing regulations. However, new services and opportunities were expanded, like telemedicine and increased access to MAP, allowing stable patients a 28-day take-home methadone prescription and waiving the requirements for in-person consultation to obtain a prescription of Butte. Services in single-room occupancy hotels, mobile outreach services increased, to name a few. All these are in line with people who use drug-centered approach. A good practice model recognizes that some people will receive services well and do well in that model, and some won't. But people who use drugs and those with lived experience can best inform the development of these models and their application. In some, harm reduction can help identify and address social determinants of problematic drug use. As important, we must realize that harm reduction is quality health. Thanks.
Thank you for that those framing thoughts. There's so much in there that is valuable, and I look forward to having people who use drugs, staff from National Harm Reduction, join us in the webinar. We also have, as Dr. Salandi mentioned, we've formed a board, or we are forming a board of people who use drugs so that we can authentically engage people whose lives are impacted by the work that we do at AIR Cares. And that means involving them from the very beginning in making sure we're asking the right questions, having them involved in determining what kinds of pursuits we should be thinking about and how to engage in that work in the communities, having them part of the research team and helping us with interpretation of data and analysis, if appropriate. So involving people who use drugs and people whose lives we are trying to impact is not just a nice thing, but again, an essential thing to make sure that we aren't wasting our time with our research and that we are putting forward the most relevant types of information and impactful information. So thank you. I would like to introduce to you Dr. Elizabeth Salisbury. She is an associate professor in the Department of Family Medicine and Community Health and is faculty for the Addiction Medicine Fellowship at the University of Wisconsin School of Medicine and Public Health in Madison, Wisconsin. Dr. Salisbury Afshar is board certified in family medicine, preventive medicine, public health, and addiction medicine, and her expertise lies at the intersection of these fields. Her work has focused on expanding access to evidence-based substance use disorder treatment and harm reduction services. Past public health roles include serving as medical director of Behavioral Health System Baltimore, medical director at Heartland Alliance Health, healthcare for the homeless provider in Chicago, and medical director of behavioral health at the Chicago Department of Public Health. Dr. Salisbury Afshar received her MD from Rush University Medical College and her master's from Johns Hopkins Bloomberg School of Public Health.
Thanks so much, Dr. Lattimore, for inviting me here today and also for hosting this really important series of conversations. I was specifically asked to talk about some of the work that I contributed to when I worked at the Chicago Department of Public Health. I was there between 2016 and 2018, so I'll apologize in advance. Some of this work may, at least the data is going to look a little bit outdated, but I think that the key points are ones that I will sort of highlight as I move through sort of quickly. Really, the work that we were focusing on during that time, at least in terms of epidemiology, was really trying to better define and describe what was happening in Chicago as it relates to the opioid overdose crisis that we were experiencing, and specifically trying to look at associations between social determinants of health and overdose mortality. Again, I just want to give a little bit of contextual background to give folks a sense of why we felt this work was important at the time. So when I took the role in 2016, although it feels hard to believe now, given sort of how much focus there's been in improving epidemiology and our understanding of overdose deaths, in 2016, at least in Chicago, we had very limited reporting on overdose deaths. And when I took the job, there was pretty significant political focus, like in many other parts of the country, on really trying to reduce opioid prescribing. It was a brand new role that I was in. And so the focus was, you know, Elizabeth, you really need to focus on getting doctors to prescribe less. We were very focused on pharmaceutical industry and unethical practices. There was a lot of focus on, you know, there was a push for us to focus on trying to educate patients about risks related to opioid overdose. At that time, I had already been working in first Baltimore and then Chicago. In Chicago, I had worked at Healthcare for the Homeless. And nothing that I was seeing sort of in my own practice and also in talking to community partners was consistent with this sort of national story that we had heard time and again about, you know, everyone's initiating with opioid pills and then they're eventually transitioning. At the time, again, we had very little data that was publicly available, but this report had just come out, the one on the top, from Chicago Cook County Task Force on Heroin, that reported that about a quarter of overdose deaths involved other opioids, which were assumed to be prescription opioids. Again, this is where sort of having those community partnerships is so critical, because I looked at this and I thought, this is just, again, not what I'm seeing, not what I'm hearing. So one of the first things we did was actually partner with the medical examiner to say, we want to have a better look. We want to understand the demographics of who's being impacted. We want to understand the substances that are involved. And without going into a lot of methodologic detail, we did identify that there were some differences in how medical examiners were defining deaths, and then subsequently how our epidemiology team had been interpreting those results. And so as we reconducted the analysis, what we found is that it was actually a much smaller proportion of deaths that had involved opioid pain relievers, and a larger proportion of deaths that had involved heroin and fentanyl. Again, at this point, this all seems very obvious because this is a trend that we've seen in the rest of the country. But at the time, you know, again, what we were trying to do was really understand what was happening locally, so that way we could better frame our interventions and the work that we were going to do in the community or with the community. Then when we look at overdose death rates, this is again from 2016, we saw that in Chicago, our overdose death rate was about double the national average or the national rate. And when we compared what was happening in Chicago to what was happening nationally, we saw significantly higher rates of deaths related to heroin and fentanyl, relatively speaking, much lower rates of opioid pain relievers, and methadone rates were about the same. We looked at age demographics of who was dying of opioid-related overdose deaths, and we saw some really different trends in Chicago. So we saw the highest rates of death actually occurring between 45 to 54-year-olds, followed by 55 to 64-year-olds in Chicago. This was a very different picture than what was being seen at the national level, where the highest rates of death were among younger populations, 25 to 34-year-olds at least in 2016. And then we went on to look at race and Hispanic origin status among decedents or people who had died of opioid-related overdose, and again, saw really different trends in Chicago. Nationally, at the time, white non-Hispanics had the highest rates of opioid overdose death. In Chicago, we saw dramatically higher rates of Black non-Hispanic Chicagoans dying of opioid-related overdose, followed by white non-Hispanic and individuals who are Hispanic. And so partly why we felt this work was so important at the time was that we needed to have a better understanding of what was happening locally. And really a lot of it ended up being around changing the narrative, really describing what are we seeing, who is being impacted, how do we give voice to the communities and the individuals who are being most impacted, and also making sure how we are allocating resources is equitable and aligns with who's being, who is being the most impacted. We then looked at the location of residence of everyone who had died of overdose, and you'll see this map on the left side. Each dot represents a death in 2016. And we then looked at rates at the community level. And so the map on the right, this is the city of Chicago. And what we saw is that some communities on the west and south sides had the highest rates of overdose. Now, for folks who are familiar with Chicago, you will know that it is a highly racially segregated city, and probably not surprising based on the data from the previous slide. The communities with the highest rates of opioid-related overdose are also communities that are predominantly African-American or Black. The next thing we wanted to do was to try to have a better understanding of how social determinants may be playing a role and what associations exist. Chicago Department of Public Health had been using the Rockefeller Institute's Urban Economic Hardship Index. I want to acknowledge this is not necessarily sort of a cumulative look at all social determinants of health, but it was, this was data that we had access to. So essentially this economic hardship index looks at 6 indicators by census tract. So it looks at unemployment, it looks at dependency, so the percent of population under 18 or over 65. It looks at the percent of people older than 25 years of age without a high school degree, income level, so per capita income, looks at crowded housing, which was defined as percent of housing units with more than 1 person per room, and it looks at the percent of the population in that census tract living below federal poverty level. And the idea here is that you use these 6 measures to provide a more comprehensive assessment of economic hardship, and that is more a more representative picture than any of these single measures by itself. Then each indicator is standardized, and the average, we sort of average out a score. So each individual census tract area has a hardship score ranging from 0 to 100, and then we put those into sort of categories: low, medium, and high economic hardship. So once we did that, we then overlaid overdose deaths, again, to get a sense of whether or not there were differences, or there were associations, I should say, in overdose death rates based on economic hardship index. And the map on the left sort of shows that visually. And then when we did the analysis, we analyzed for 3 subsequent years, 2015, 16, and 17. And what we saw was that in each of these years, we saw the exact same trend, which is that communities with higher levels of economic hardship had higher rates of opioid-related overdose. And I will say, I think sometimes in public health work, especially as someone who practices and does a lot of work in the community, for folks who have lived this, for folks who work in this space, like, I think this can seem really obvious. Like, yeah, no kidding. Like, when I give talks or partner with community members, like, yeah, Elizabeth, I could have told you this. You didn't need to do all of this analysis, and I hear that. The reality was, particularly at that time, again, we really felt that we needed to use the data that we had available to be able to change the narrative and to change the story about how we needed to focus our energy, so that we weren't solely focusing on reducing prescribing, but that we were really being responsive to what we were seeing at the city level. We know that social and economic factors like poverty, unemployment, educational attainment, income, both have associations with the development of addiction as well as risk for overdose. And particularly at the local level, where the trends we can see can look really different than what's happening nationally. I think it can be easy to sort of be distracted, if you will, by what's going on somewhere else. But it's really important to have a sense of what's happening locally, so that we can develop strategic and equitable interventions. And I'm happy to talk more about sort of how we thought about and how we used this information to frame our next steps and how we partnered with community. But I think I'll save that for discussion and pass it back to Dr. Lattimore.
Great, thank you so much. So the use of data, some of the things that I took away from your talk was really about how we shouldn't assume the national narratives. We should look into opportunities to use our own local data, our own stories locally, and figure out what our populations need, because the narratives are sometimes guided by things that aren't driven by data, may not be evidence-based, and may not work for the communities that we serve. And having that data, bringing it all together is a challenge for sure. No doubt about that. But there are states and communities that have come together to bring to the table data across sectors. So for example, the Massachusetts Department of Public Health, through some support from legislation, have been able to create a data warehouse. And those data, the data that are in this warehouse are from housing and from arrests and employment and SNAP, TANF, and so all of the social determinants in one data set at the individual level is an amazing feat. And these are data that actually AIR Cares is going to be using for a future project to look at not just the community level associations with overdose, as Dr. Salisbury Afsar just shared, but to think about how individual level and community level indicators of social determinants interact to produce overdose deaths, and how that is conditioned by residential segregation, and how that can differentially affect people of color to increase overdose risks, the overdose risks that we see, the higher rates of death. So having these data to answer questions takes sort of a collective community agreement that data are important and that we want to use them to inform our decisions. So thank you very much for sharing the research. If I can have all of the panelists turn their cameras back on, we're gonna have a discussion. We've got, please enter your questions into the Q&A box. But we have several questions already that we can go ahead and get started on. And one of them is to talk about the pink elephant in the room, so to speak. And you touched on this a little bit, Dr. Salandi. You know, the current administration has expressed some unprecedented support for harm reduction. And that there's been a lot of discussion about the use of federal funds for certain harm reduction tools like crack pipes. It's caused a lot of attention and a lot of concern in the harm reduction community. So what are, everyone is welcome to chime in here, but what are your thoughts on what needs to be done in the face of this controversy?
Well, I will tell you one of the things that is being done is that the SAMHSA steering committee group that was put together drafted a letter to Secretary Becerra and Dr. Gupta outlining why their position is wrong and why allowing federal funds for the purchase of clean syringes and smoking materials is the proper way to address the opioid epidemic. And so I think that there's pushback from a lot of corners in the harm reduction movement, and quite frankly, across the board. And so there are things that are being done, but I think one thing is for people to call their legislators and say to them that this is not evidence-based, and they should, quite frankly, push back on some of the conservative legislators and their positions.
Great, thank you.
I think, Dr. Lattimore, when I guess there are a couple things. One is, the reason when I was in the Obama the Obama and the Biden administration. In the Biden administration, why we emphasized harm reduction so much in the beginning, I guess I want to give 2 data points. 13% of people who have a substance use disorder get treatment, and we had 100,000 deaths. And so harm reduction, as Anthony so eloquently said, it's about engagement and meeting people where they are, but not leaving them there. And so I think so much of this is educating people about what it means and what it means to someone. I've had many people who are parents who lost loved ones who said, I wish I knew about a syringe exchange. I wish that my son or daughter could have been able to go there. It may have reduced their other illnesses, their bloodborne diseases. It may have saved their lives. So I think when we're thinking about that, that's the most important thing, is not to give up and to start. And I understand it's frustrating, but to start educating and talking to people. And then there was one other thing that came up about what role harm reduction plays in prevention. If we reduce adverse childhood experiences, if we reduce risky drug use, all of that adds up to prevention as well. So I think it's the entire continuum of care has to include harm reduction.
I really agree with everything that's been said already. I think, I have all of my work is really focused at the local level. And so when I think about what is our response at the local level, it's a few things. One, I think we should push back where we can. This can be a really critical engagement tool. In terms of, as Regina said, engaging with folks who maybe wouldn't otherwise be engaged. I will say in my work in Chicago, we were really aware that a lot of folks who, particularly in the communities with the highest overdose death rates, there was not a lot of injection drug use. We didn't have good epi data for it, but every community partner we worked with, like every patient I ever met from there, like this was a consistent thing that we heard. And we knew that we couldn't rely on naloxone distribution solely from SSPs, because SSPs, syringe service programs, weren't always, there was stigma, there were a bunch of reasons why we thought people might not be using them based on conversations with community partners and people with lived experience. And I think we have to really broaden sort of the ways that we work to engage people. And if pipes are a way that folks who aren't injection drugs are going to be more open to receiving services, to engaging in services, to getting, to receiving overdose education prevention and naloxone and other services, then I think we should be doing it. Now, if we aren't allowed to use federal dollars to pay for it, every community-based harm reduction program knows, like, they're super crafty and they're going to find ways. It means we have to look to philanthropy, we have to look to other places to be able to supplement that. But community-based harm reduction agencies are used to this. Everything's a patchwork of funding. So while it's not what I'm saying is the ideal, it's the reality. And until we're able to use federal funding, then I think that that's what we should be doing. And for the folks who have the infrastructure to be able to conduct research, to understand how this impacts engagement, we need to do that too, because it gives us more teeth in the argument that we need to be able to expand to these types of services. So I think it's a lot of those things, but I would say we don't want to just throw it out and say, well, that's done. We do need to be able to use any tools we have for engagement and that will help improve health. And then we need to study it to be able to continue to advocate to be able to receive federal funding for those services. Absolutely.
And study it with people who use drugs at the table, 100%. So here's a quick question. Actually, Dr. Salandi, there's some curiosity about whether or not there's going to be a National Harm Reduction Conference this year. So you have a moment to plug it if you want.
Certainly. So there is going to be a National Harm Reduction. Well, am I on mute? Well, there is going to be a National Harm Reduction Coalition conference. It's going to be in San Juan, Puerto Rico. The dates are the 12th, actually the 13th to the 16th. The 12th will be the pre-conference date. And we are launching this week the website for the conference. And so a lot of stuff is going to go out this week. And just look to your inboxes and access the site, the conference site off the national or harmreduction.org. So that's the plug.
Thank you. So Here's another question about harm reduction. What is the place of harm reduction in prevention? What harm reduction strategies address prevention?
So harm reduction has a place, as Regina said, across the spectrum, from prevention to treatment to recovery. And I think for prevention specifically, in my talk, I said that, there are predictors to initiating drug use. And we need to start focusing on that, right? At least paying some attention to that. So, we know that childhood physical and sexual abuse, as well as neglect, predicts substance use. We conducted studies and have focus groups and of individuals who have problematic drug use, and we asked them, can you tell us about your life? And what they will say often is that they had some, a large percentage of them say how they've had or experienced trauma because of physical abuse, and sexual abuse. And there's a disproportionate number of those individuals who are young Black women and young Black boys. And so I think that in prevention, we need to start looking at some of those social determinants and breaking the cycle, right? And making sure that how you break the cycle, you still have to do treatment, you still have to do recovery and making sure people stay in recovery. But you also have to bring a humility and compassion and understanding and radical love to working with people who use drugs and understanding how you have to meet them where they are. And that's the reason why SSP is so important, because the individuals who have taken up this responsibility of providing harm reduction services, they do it with compassion, love, and understanding. And so that individuals feel that it is a safe place to go to and speak to someone, so that if they are ready to go into treatment services, that person is there to refer them to the appropriate service.
Mm-hmm.
Can I respond briefly? Is that okay? So I would just say, I think the intent of the question was about primary prevention, but I also just want to acknowledge that harm reduction as a whole is prevention across the board. It's preventing death. It's preventing, infections related to injection drug use. It is prevention at every level, primary, secondary, tertiary. When we talk about primary prevention, a lot of times the other thing that I see is that when folks talk about primary prevention, they're really narrowly focused on preventing use, any use of substances. And as a clinician, when I think about primary prevention, it may be about preventing use, but it's also just as equally about preventing the development of use disorder or problematic use. And we know that the factors that really contribute to folks sort of going from any use to having more problematic use or health, and other social problems related to use has, I don't have an exact number, but in clinical experience, I would say 90% to do with all of those other social determinants of health, racism, stigma, poverty, housing, trauma, all of those things. And so, yes, and I think if I put on my clinician hat and I think about primary prevention, exactly everything Dr. Slaney just said, we in healthcare have a tremendous opportunity because we often are seeing people much earlier in the course. And if our response is like, oh, you shouldn't do that, oh, it's bad, oh, I can't believe, and it's a very negative, punitive response. And we know our patients have those experiences. We are actually doing more harm than good. We are actively encouraging people not to come back and talk to us. And so I think harm reduction has a place everywhere in clinical practice. I know that is not the origin or the history of harm reduction, but I also think it really fits in clinical practice and how we work with people. And so I really appreciate the question. And I would encourage all of us to think about how we can use the harm reduction philosophy more in our day-to-day work, no matter what sphere we're working in.
Right. And, it's worth mentioning that it's early use of, using drugs at an early age, not necessarily drug use that has been associated with long-term consequences, substance use disorder specifically. That's just what the data say. Most youth are exiting high school with having already initiated, and many do not, that does not devolve into problematic use later, especially if it's not started at the early age. So another question that that's come up here had to do with the suggestion of having money, tax credits, and supporting families through, providing parents with funds. This person suggesting that, sending money to families might not lift kids out of poverty and may actually exacerbate substance use disorder issues. Does anyone want to take a stab at responding to that?
I'm sorry, I don't have my video back on, so you have me with this photo.
It's a lovely photo.
So we've heard this criticism about the child tax credit. I think there's a couple points. The first is that it is an advance on the child. It's a tax credit. Individuals would have gotten it. It's just that it's spread out over the year as opposed to waiting until tax time. So that's one thing. So it's not necessarily additional money. It's just that you get it at a more appropriate time, probably for people's needs. And then secondly, I think that, the studies that have been done haven't shown that, that it has led to additional substance use, substance misuse. Certainly there are concerns about, risky drug use. However, I don't think we've seen any evidence of that. And again, I think certainly the benefits of lifting children out of poverty and families out of poverty really outweigh any of the challenges that we may experience. Thanks.
Great, thank you. Well, we are at 1:58, and I just wanted to thank the panelists, everyone, for some great food for thought, a great way to start off our series and frame the rest of the year. We will take a closer look at each of the social determinants. So if you came hoping to learn more about employment, for example, and you didn't quite get that, we're going to cover it in a future webinar, and hopefully you'll join us for that. So just providing here, share my screen, the dates of the webinar coming up, and please go to AIR.org, AIR Cares to learn more about the webinar series and register, and we'll be sending out more information about upcoming webinars. The next one we'll have next month in March, we'll discuss healthcare access and quality as a social determinant, and we'll have representation from policy. Shelley Wiseman from O'Neill Institute will join us. Hiawatha Collins from the National Harm Reduction Coalition will join us. Ayanna Jordan will be there to discuss racial equity in healthcare. Kima Taylor will provide some harm reduction leaders guidance on how to pursue healthcare financing for their organizations. So we have a great lineup for our next webinar, and hope to see you there. Thank you.